Good afternoon. My name is Judy Canary. I'm the Associate Vice President for Academic Affairs in the School of Professional Studies at Anna Maria College. I welcome you to Anna Maria's Life After COVID-19 webinar. In this webinar, our panel of experts will be addressing post-COVID considerations for planning and best practices for towns, cities, schools, and businesses. Anna Maria College is located just outside of Worcester in Paxton, Massachusetts, and we're celebrating our 75th anniversary in 2021. We are a private co-educational institution inspired by the ideals of the Sisters of St. Anne to prepare students to become ethical leaders with strong knowledge and skills necessary to address the rapidly changing needs of their world. Over the years, Anna Maria College has supplied many towns and cities with alumni who serve in public safety sector in positions such as police and fire chiefs, law enforcement, EMTs, paramedics, emergency managers, federal and state public safety officers, nurses, teachers, and practitioners in the fields of mental health counseling, psychology, human services, addiction studies, and social work. We also have majors in health emergency management, health sciences, business, digital marketing, sports management, IO psych, health administration, art, music, and liberal arts. We offer undergraduate, graduate, degree completion, and certificate programs, some of which are on campus and or online. Please visit our website, www.annamaria.edu, for more information on our dynamic programs. Thank you all for your interest, and I want to especially thank today's panelists, Dr. Matilde Castiel, Dr. Greg Ciottone, Ted Flanagan, and Dr. John Pratico. I wish to now turn this over to our webinar moderator, Mr. Hugh Drummond. Hugh?
Thanks, Judy, and welcome everyone. First, a few housekeeping items. This web discussion is being recorded, and we also have members of the news media with us today. Today's program will feature brief remarks from each of our panelists, and then move to audience questions and some discussion. I already have some questions that were submitted when people registered, but feel free to submit questions today through the Q&A feature at the bottom of your Zoom screen. After the year we have experienced, and with the vaccine distribution underway, there's a lot of ground to cover, and we'll do our best. As Judy mentioned, we are joined today by an esteemed group of experts. Before we hear from each of them, let me briefly introduce them. Dr. Matilde Castiel is Commissioner of Health and Human Services for the City of Worcester. Dr. Castiel is also a physician and an Associate Professor of Medicine at UMass Medical. Dr. Greg Ciottone is Medical Director of Anna Maria College's Master of Health Emergency Management Program and a nationally recognized leader in disaster medicine. He is Director of the Division of Disaster Medicine at Beth Israel Deaconess Medical Center, an Associate Professor at Harvard Medical School, and President of the World Association for Disaster and Emergency Medicine. Ted Flanagan is Director of EMS Programs at Anna Maria College. He is also a firefighter and paramedic for the West Boylston Fire Department. And Dr. John Pratico is Director of Psychology Programs at Anna Maria College. Dr. Pratico is a licensed mental health counselor, as well as a licensed clinical psychologist in the Commonwealth of Massachusetts, and a member of several working groups for the City of Worcester. At this time, let me turn to our first panelist, Dr. Castiel, for a look on where we are now locally and how we are addressing the needs of vulnerable communities. Dr. Castiel?
Myself. Thank you so much. I appreciate you inviting me here. And as all of you said, both of you have said that it's been an incredible year. And if we could put up the slides, that would be wonderful. And I can tell you a little bit about what we've been doing in Worcester. You can go to the next slide. And what we think should be happening towards the end of this. So some of the things that we've worked on certainly has been shelters. We started a COVID-19 Health Equity Task Force with UMass, certainly community testing, and most recently looking at vaccine rollouts. Next slide. So prior to COVID, our focus has always been on homelessness. And in particular, we started the Housing First Coordinating Council to look at how we provide housing for those who are chronically homeless. Next slide. And I want to say that I'm going to have these slides to share with all of you at the end of this. And so I might be going through some things and you may want to look at some other pieces here in depth. But what we learned during the COVID time is our first goal was really to look at the shelter population. And we had our shelter, our SMOC shelter, which we had one, was 160 clients living in one small area. We had one overflow shelter, and we had to separate everybody. And that was the goal that we started in March. And then while we were doing that, we learned a lot of things about the homeless community and what needs to happen. But what we ended up doing as we separated the shelters into 25 people each one was to bring primary care services, to bring substance use treatment with Suboxone or methadone, mental health treatment with telehealth, which was one of the best things that came around during COVID. We brought financial assistance. The checks were brought into people when they were given by the federal government. We had benefits access and workforce development. Next slide. So this is sort of the timeline of what we did, starting in March and dividing it into the shelters, and then really trying to look to test the homeless community to make sure, because they leave during the day and they're out in the streets. And what we found out was that 39% of the population of the shelters actually were positive, and they were asymptomatic positive, the majority of them. What we learned during that process is, again, like we talked about, is bringing healthcare and all the other ancillary services, but we also ended up housing 40 of the clients that were there. And then we've developed a new model of care, or at least working towards a new model of care towards this. But I just want to minimize this. Hold on one second. And part of it has also been that we saw some of the issues that we're having with people at the shelter, in particular, women who had been prostituted and who have a lot of trauma, and figuring out what are some of the ways that that we can work with them. And we opened up, along with Lyft, opened up what's called Harbor, and it's a women's shelter really for traumatized women, women who've been trafficked. And so that was the intention of that. And then SMOC ultimately ended up opening one more shelter so that we can divide the shelter into less people in the shelters. Next slide. So what we learned from this process was that we needed a new model of care, and then something that gives people dignity instead of being crowded into one room. So we're looking at the idea of utilizing hotels to shelter people where they have individual rooms, or they share a room with one other person and they have their own bathroom. And this is part, we hope the pandemic never happens, but we don't know what's next to come. And so how do we prepare ourselves from lessons learned from what we did with the shelters? And again, on-site client healthcare and services. Even though we know that Housing First is the model of care, we still need to bring some services to the shelter to stabilize people that were there. And then once we stabilize them, they were more willing to go into housing. And that's what we learned, and that's how we housed 40 people through that process. And then the idea of changing stigma around mental health and homelessness, and really get everybody involved in this process. Our belief is that no one should be homeless in this day and age and in our country. And the overall result is we'll decrease cost in healthcare, and that should be the quality care model that we use. Next slide. The other thing that we did during COVID was really the UMass Memorial and the city of Worcester started the COVID-19 Equity Task Force, where we brought community members into this task force to hear their opinions, hear their thought process of what needs to happen, and to review the data and figure out who's being affected and how do we best help. So next slide. So this COVID-19 task force had 4 groups. One was to look at the data so we know how to function when we have the data in front of us, what neighborhoods are being affected, what community groups are being affected. We had an outreach and education working group, a testing group, but then rolled out to be the vaccine rollout group, and then the access group. And that's one of the problems that we've had in particular in communities of color, is really the access to healthcare and to information. Next slide. Some of the data that came out of the COVID-19 task force is really to what were the highest areas that were impacted by COVID and yet had the lowest testing. And so some of those areas, if you know Worcester, University Park, Chandler Street, South Worcester, and again, these are the areas where mostly communities of color live. Next slide. When we looked at a lot of the data, we found that 46% of all youth cases from 0 to 17 were Latinos. Also that, and you can see the Latino is the orange at the bottom, and the Black or African American is the light blue. And again, when we're looking at ages of who was affected, again, Latinos were impacted the most through the ages of 30 to 59. And so when we're trying to roll out the vaccines, if we look just at our data, the most affected obviously are a younger age group, and that's what we thought we were going to be able to focus on. Next slide. And then overall, 10.4% of the city's population in Worcester had COVID. 11.5% of the Black population had COVID, and the highest was the Latino community at 15.8% of the Latino community. Next slide. So what the data showed us is, as you can see in the purple above, what neighborhoods were most affected: Main South, Chandler Street, the Vernon Hill area, and the Latino and Black communities were the most impacted by COVID, and that younger groups of Latino and Black populations were positive for COVID. And then looking at how do we go into the community, how do we do a targeted outreach into the community, and that's actually where I am today, is vaccinating in the Main South area at the YMCA here. Next slide. These are all the tests that were administered were 14,717 COVID tests. And you could see the areas that the COVID tests were being performed. The highest numbers were at Edward M. Kennedy Center and Our Lady of Loretto Church. Next slide. So the rollout for the campaign and how we looked at it was, first and foremost, we started out with town halls. So we've done town halls probably in every community in Worcester, every organization in Worcester that has requested, and others have seen it. And if they requested, we go ahead and do that, and basically talking about the vaccines. And at that time, it was really Pfizer and Moderna that we were talking about. And most recently, we're going to start doing one just on the Johnson & Johnson vaccine. And then the goal has been really to go where people are. And so we've started our vaccination clinics through Health and Human Services. The Department of Public Health had their senior center was open for clinics until most recently that it's closing up due to the large vaccination sites. But we know that those large vaccination sites are not places that community feels comfortable or can access the ability to sign up. And so that's why Health and Human Services has mobile clinics that we go from site to site. There's also been push, obviously, CVS, Walgreens, Big Y, again, all the other places that you can access, but the mobile clinics and going to where people are is really the method of care when you're going out into vulnerable communities. Next slide. And these are some of the places that we've gone with our mobile clinics. We've done the shelters, which was actually part of phase 1. And we've gone through all the Worcester housing authorities to be able to give vaccinations. And we've gone through community sites. And most recently, we're one of 20 cities and towns in Worcester that have been given the equity vaccine. So we have 800 vaccines that we're supposed to be given per week to communities of color, immigrant community, vulnerable communities, people who have no access to computer or transportation. Those are the people that we are seeing. Next slide. And if you look at what's been happening, this is from the Mass DPH site, and you can see that people of color make up only 16% of the total vaccine doses administered in Massachusetts in comparison to 71% of the doses that have been administered to white individuals. And this is why we have the equity vaccine that we're doing on a weekly basis. Next slide. So very important just to understand the difference between equity and equality. And people say, well, these vaccines, why can't we have it in our neighborhoods? I don't know if most of you have seen this picture, which differentiates what equality and equity is. And you can see the young man with the 2 boosters up. And basically, you bring the needs to those that have been affected the most. And that has been our goal with the equity vaccine. Next slide. So some of our strategies that we look at is to validate. When we're talking about systemic racism as part of what's caused the social determinants of health, to center the Black and Brown immigrant voices, and it's important to hear the voices of the people who are being affected by this, and meet vulnerable populations in their communities. And this is exactly what we're doing with our equity vaccines. We're going to churches, we're going to places in the community that people feel comfortable with. And then sustain all the cross-sectoral efforts, everything that everybody's been inputting and working together. We've got to continue to do that. Create and establish and sustain a model of care for communities of color and marginalized communities. And that's hopefully what we'll bring forth, and give Black and Brown and immigrant voices a seat at the table. It's incredibly important to hear the voices of the community and what their thought process is. Next slide. So I don't know if most of you have heard, we're not going back to brunch. The thought process is we're not going back to the way we were. We need to look at our system a little bit different. We need to value our essential workers, and they have been in the front line during this whole process, and pay them livable wages and health care. We need to rebuild our collapsed food system, develop a better system for distributing food, eliminating food waste. As most of you know, a lot of time farmers had to throw a lot of their food away, and how do we invest in local food production? To rethink monetary policy for public goods, housing, basic needs, and public services are incredibly important. Work as a global economy. How do we all work together? How do we all, if we're in need of something, who's going to work together to bring the PPE, all the different pieces that are needed or have been needed during this COVID-19. And then, measure societal success through employment. We measure societal success by the GDP. Well, let's think about employment. Let's think about access to basic needs and investments towards infrastructure. These are all things that are important, and we need to spend our money in being able to do that. And obviously, we know we have money. We've been able to put it out there, but let's spend it in the things that we need. We need to invest in environmental justice and repair, and ultimately invest in research and public health. And I think that's actually me getting my COVID vaccine, the Pfizer vaccine, in the trials in September. And that's part of it is making sure that we have people from the community getting vaccinated and talking about the vaccine and the safety of the vaccine, and all the hesitancy that exists, or the misinformation that exists, that we are able to talk about the vaccine and why it's important. Thank you.
Thank you, Dr. Castiel. Just so everyone knows, we do have some questions coming in, and we will get to them after we hear from our panelists. So continue to submit questions, and we'll get to them shortly. Dr. Ciottone, things are starting to open up. There's talk of herd immunity by fall. What are you seeing and hearing nationally? What's working? What keeps you up at night?
Well, thanks, Hugh. And first of all, let me quickly give you some background. I actually grew up in Shrewsbury, was able to live my dream of going to UMass Medical School, which I won't tell you how long ago that was. But also, Dr. Castiel, and where you are right now reminds me that when I was in medical school, I was actually a member of that YMCA. So it all comes around. But yeah, I'm going to talk a little bit about where we are. I'm sorry, where we were, where we are now, and where we're going to be. And I'm going to try to do that all in 10 minutes. So I'm not going to take a really deep dive in anything, but I really look forward to the discussion and question and answer period afterwards. So let me just pull up my slides here. So again, here we are in the midst of this COVID. Everybody knows we've been through the 12 months plus. We're now in the vaccine rollout and this idea of non-pharmaceutical intervention, down regulation. So mask wearing, social distancing, et cetera. How do we balance that out? Well, first of all, we talk about this being a generational event. Well, is it really? No, not really. Now, a pandemic of this scale, of course, we haven't seen since about 1968, but we certainly have had other opportunities to see what pandemics look like. And this is from 1918, these two pictures, and oh, wow, look at that. They understood what masks did and how they are useful back in 1918. What a surprise, tongue in cheek. So we have seen pandemics since 1918 and since 1968. So as we all know, the last two coronavirus pandemics that occurred were the SARS of 02 to 4, and then of course the MERS around 2012. As you can see, neither one of those had vaccines created. And why is that? It's because they just sort of petered out on their own. So here we are now at about 2.7 million deaths worldwide of this COVID vaccine. And we're talking about contagiousness now, the R naught value, or how contagious these things are. The influenza viruses that caused those bigger pandemics in the past all had an R naught of about 1.6 to 8-ish. That means if I have it, I will give it to 1.6 to 1.8 people. This is, it's an estimate, but these are rough averages that we use. If you look at the coronaviruses, they are worse. They are more contagious than H1N1 viruses. And of course, that's a concern going forward, especially now that we're seeing new variants that are even more highly contagious. So where have we been? Well, this has really been an experience, pandemic and experience of two worlds, right? The graph on the left, don't worry, I know it's hard to see, represents different countries early on in this pandemic. And as you can, and these are cumulative deaths, okay, cumulative. So as you can see, a number of countries really took off and then they plateaued. These graphs will never go down because they're cumulative, okay? But you'll note a number of lines there that never plateaued. And unfortunately, the United States is one of them. And this other table here is even more concerning. If you compare, United States to, let's say, two other countries with not the same population, but not too far off, and you look at the dramatically different death rates in these two countries, says to us that we really could have done a better job here in the U.S. So where are we now? It's this whole idea of getting vaccines, getting the vaccinations, getting vaccine into arms, essentially. So this is a balance now of essentially disease prevalence as a risk analysis of when we're going to start rolling back some of these NPIs and non-pharmaceutical interventions and how we might do that. First of all, let me make a general statement. The moment a proven healthcare preventative measure like mask wearing, and you saw the picture of 1918, the moment that became a political statement is really the moment where we lost the ball game. It is a proven public health measure, and we all have to understand that. What we need now is to really roll out this vaccine. We are fortunate to have 3 very good vaccines, and quite frankly, the Johnson & Johnson is a game changer, okay? Johnson & Johnson is a 1-dose vaccine as opposed to 2, and it also does not have that cold chain hurdles to the degree that the other 2 vaccines have. It's a real game changer. So what do I think we need to do? I think we need to get on a war footing like we did in World War II. But back then, instead of having Rosie the Riveter, we need to have, you name it, Vanessa and Vinny the vaccinator. And we also, in addition to the vaccination sites, I would argue, in light of the Johnson & Johnson, we need to take another step. Why are we having our most technologically not savvy people, segment of the population, elderly, and the most not mobile or limited mobility portion of segment of the population, the elderly, having to seek out these vaccines by going on websites that often crash and trying to find vaccination sites and go through that whole process? Why don't we, in addition to those vaccination sites, why don't we take the J&J vaccine, either with EMS, off-duty or retired healthcare personnel, let's take the vaccine to the people. Let's match census data with maybe a 1-question website that says, will you take the vaccine or not? Yes and no. Match that up, do some neighborhood mapping, say, okay, this neighborhood will coming to vaccinate your neighborhood next Tuesday, and push it out that way to actually double the effort that we're doing now as the vaccines become more and more available. Because as President Biden said, we expect to have enough vaccine by the end of May to cover the entire United States. So maybe we need to look at a little bit of a different strategy and about how to roll this out. It's all about the logistics right now. We've had the wonderful developmental process, brilliant scientists making the vaccines. We've had the public health experts, everybody else, infectious disease experts, really doing a tremendous job of getting us to where we are now. And now it's all about the logistics. It's all about this idea of emergency management, getting the vaccine from the factory to the arm, and how are we going to do that? So right now we're living in these CDC post-vaccination guidelines that came up, I think, last week. But if you look at them, there's still a little, we're not quite sure, and in fact, most industries and most universities, Harvard University, for instance, just sent out their guidelines and said, yes, what the CDC is saying as far as vaccinated people being able to get together, in homes, other places, perhaps without masks, if everybody's vaccinated, we're not doing that as an institution, and many places are not doing that. So we're still kind of in that gray zone of exactly where we're going to go with this. What's the concern about variants? Until we get that vaccine-mediated herd immunity, and not just in the United States, globally, we are at risk of creating variants that are going to get more and more concerning. This article in the New England Journal of Medicine came out 2 days ago, and it's quite concerning. It shows, at least in this study, that potentially the AstraZeneca vaccine may not provide coverage or protection against the South African variant. Now, the jury's still out. This is not conclusive, but it's showing some indication, which is a concern. But the reality is, the more that we allow the virus to have a substantial grip on a large population, is more we allow it to evolve and to create a variant, which we may actually have a lot of trouble with later. Because don't forget the nightmare scenario. What I always talk to my fellows, teach my fellows and students about is, you saw all those different pandemics we've had in the last, 100 years, but including the last 20 years. We've had all these opportunities to get this right, from the idea of once the outbreak happens, trying to contain it. If it's not contained and it grows, becomes a pandemic, once you have community spread, at that point, until we can bridge to effective therapeutics and effective vaccinations, we need to do non-pharmaceutical interventions, mask wearing, social distancing, lockdowns if needed, et cetera. It's public health. It's the community saving itself. It's not a doctor saving a patient. It's the community saving itself. And unless we get this right, imagine the nightmare scenario. Either a novel virus or perhaps a variant emerges and has the R naught of not COVID, but of measles and mumps, which is more than 10 times more contagious than COVID, has a low dispersion factor, which is the K factor, how well you can disperse it if you're yelling or singing or what have you, but has the case fatality rate, not of COVID, which is somewhere, depending on where you live in the world, 1 to even upwards of 6%, but usually around 1 to 2% case fatality rate. Instead of has a case fatality rate of Ebola, which is 50 to 70%, or rabies, which approximates 100%. I would argue if that novel virus emerges, or God forbid that variant emerges, that would not only decimate our healthcare systems and our economies, it would actually threaten us as a species. So we need to get this right. So what are the key factors in ramping this all up and getting the vaccines out and getting vaccines into arms and then downscaling NPIs so we get back to some semblance of normal, not the old normal, but some semblance of normal? Well, I would argue that these are all the different steps. Risk assessment. It's all about disease prevalence. In one part of our country, we saw disease prevalence very high, another part very low. And that changed all along this 12 plus months of the pandemic. One time New York was on fire, then it's not. And then one time California's on fire, then it's not. So disease prevalence is important. How we downregulate NPIs is important. Testing is extremely important because we're not going to be able to know disease prevalence and health prevalence if we don't do adequate testing. Maybe we need to do contact tracing based on that testing wastewater. All these things have proven to be very effective. We need effective leadership. Right now, the kind of leadership we need is emergency management. In addition to everything else, but we really need emergency management to make all of this happen. And then we need contingency planning. Any disaster, and my specialty is disaster medicine, I always say better the planning than the plan. Any disaster plan will be good for about the first 10% of a disaster. After that, the disaster is going to turn left, turn right, and you need to be able to pivot. So the reality is, the way we get to the end of this pandemic is to get vaccine-mediated herd immunity before these more virulent strains emerge. So thank you. I look forward to the continuing conversation. You?
Thank you, Dr. Ciottone. Let's turn now to Ted Flanagan. Ted, you and I spoke several months ago about first responders and what they're experiencing. how has the pandemic changed professions like paramedics, and how has it changed academics for those professions?
Yeah, thanks, Hugh. Appreciate it, and thank you everybody for coming. So for me, the biggest change I've noticed in the profession is this eradication of complacency. I think paramedicine's only been around as a profession for maybe 50 years at this point, and yet we rather rapidly adopted this idea that we have always done it this way, and we'll always do it this way, and never shall we change. Change is a bad word. I think one of the things that pandemic has done, it's completely eradicated the complacency that all the symptomology, all the patient presentations that we've ever seen are ones that we will see going forward in the future. And these days, I haven't talked to a patient without an N95 between myself and the patient, in over a year, since last February, really. And I want to say, the almost 30 years I've been doing this, prior to that, I've probably worn an N95 a handful of times, 4 or 5 times. And so I think the pandemic has really shaken a lot of assumptions about what it means to go out to the community in an ambulance and treat patients. You start to see patients as, the disease was, not particularly well understood in the beginning, especially. You start to wonder, what are my patients a threat to me? What is really the risk of going out on an ambulance call? And so that's evolved. I think as time has gone on, EMS is, if nothing else, the types of folks that get into this profession are supremely adaptable. And I think you're seeing that across the board, that very quickly, EMTs, paramedics pivoted to this new reality that simply wearing a pair of gloves is the all you need to do to stay safe. Now that thought process has completely been abandoned, and so I think this eradication of complacency is hopefully here to stay as well. The other thing that really struck me is the resilience of the field, and I would really urge scholars, Dr. Pratico and folks in the psychology field, to look at EMS and to study EMS, because I really kind of wondered when this started happening, where there was this existential threat every call now kind of presents on some level, depending on whether you're an alarmist or not. But even as the most practical person has to admit that, ambulance calls now have stakes that they simply didn't have 15 or 20 years ago, or at least not as in your face. And yet I don't see, and this is anecdotal, so I say it probably requires study, but it'd be a fertile ground for study. I don't see a mass exodus from the field. I don't hear a lot of EMS providers leaving EMS because they're worried about contracting this disease. If anything, it's been kind of business as usual. I still solicit or receive solicitations from prospective students on a daily basis. I don't notice anybody less enthusiastic about going into EMS. And if anything, I'm getting requests and phone calls from folks who left the field to go into other pastures, who want to come back. I don't know if it's because this time of crisis has sort of engendered some feelings of service that lay dormant, or I'm not exactly sure what it is, but I think that's one thing we should probably study. Why is the field so resilient? I wish I could say that as an EMS educator, it's because we have worked hard to create providers who are resilient, right? But the reality is, I don't know that under the national curriculum there is no formal training in how to remain, engaged and resilient in the field. I know I covered in my own program. I think it's great that we tell people where the pointy end of the needle goes, but there's so much more to the profession simply than the skills and technical aspects of it. And so I like to think in our program, resilience is sort of built into it, but not, I can't claim that it's a dedicated portion of the curriculum, but I think it could be. I certainly think other professions, caring professions, emergency professions, there are some lessons to be learned from whatever it is that EMS is doing that's resulting in folks sticking out this rather trying time. And the last thing I would say, Hugh, this pandemic has reinforced my belief in educating in the basic sciences. Our program does more than what's required by the national curriculum by quite a bit. You couldn't go to paramedic school in some portions of the country and really have, a 4-week section on anatomy and physiology and almost no basic biology and finish a paramedic program. And yet I find that, if part of our job is to be an educator, is to educate our patients, and I really think that's important, then if we lack the basic science education that other healthcare professions have, that's a pretty large blind spot. So this pandemic has really reinforced for me the necessity of education in the basic sciences, biology, a couple semesters of anatomy and physiology, and then to incorporate those within the portions of the curriculum that teach, the basic disease processes and pathophysiology and that sort of thing. So, I think the profession has been changed permanently in ways that we still are figuring out and still experiencing. But those are three that sort of occur to me in the near term. And I think, the pandemic has been, I'm sure everybody that's here today has not loved the last year, but I think there's also an opportunity for the profession to grow and to evolve into something that actually meets the needs of our patients rather than this, how we've always done things, which I think, EMS always say that we're here in 2021, we're kind of at the end of the beginning. The field has, it was founded in the 70s as an organized pursuit. It evolved over the 80s and 90s. And then, the last few years, I think you've seen a lot of practices and things we've done grow kind of stale and moribund. And a lot, there's definitely prior to the pandemic, there was a lot of this sort of, well, that's the way we've always done it approach. And if there's any challenge that COVID presents that I think will have a generative effect, it's challenging this idea of stasis that we've always done it this way. Well, the old ways are going to have to change, and hopefully for the better. So thanks you. Back to you.
Thanks, Ted. I appreciate that. Let's turn now to Dr. Pratico. Dr. Pratico, obviously, the social and psychological consequences of the past year will be long-lasting. Technologies like telehealth are probably here to stay. Can you speak to how the pandemic has impacted the mental health of our elderly as well as our youth?
Yeah, absolutely. So welcome, everybody. I was saying this to some of my peers when I was preparing my talk, that I feel like in some ways I have one of the easier components of this introduction, just because so many of us have lived it. We've all, in the last year, have gone through the psychological and social implications of COVID, either directly as somebody who's been infected with the virus or has kind of seen it on an individual level or on a community level. So just one thing to think about right off the bat is when you look at kind of how research is conducted around public health emergencies, historically, there's a lot of focus, obviously, on individual effects. So, things like, feeling insecure, feeling unsafe, the emotional isolation and stigma associated with contracting the virus of a pandemic. So in addition to that, you have the focus on communities as well. So there's individual effects that are worthy of exploration in the research literature, but you also have community-focused factors that are worth exploring. So obviously we've seen this with COVID-19 with regards to economic losses, work and school closures, the stay-at-home orders, access to medical providers and access to mental health services. And so these are two areas that historically are focused on when a pandemic or any other kind of public health crisis occurs. So, in addition to that, these effects that we see are ranging from obvious things like emotional reactions. A lot of us have experienced things like distress or emerging psychiatric conditions or worsening of psychiatric conditions in the last year. So in addition to emotional reactions, we see effects along the lines of unhealthy behaviors. So things like substance use and overdose related consequences have been pretty noteworthy in the past year or so. And then another kind of unexpected or sometimes expected effect is noncompliance or inability to follow through on general medically based recommendations. So we've seen this in the past year as well with regards to people not following recommendations of healthcare providers or policymakers in the community. So, for example, breaching of stay-at-home orders by people who are either infected with COVID-19 or are just members of the general population. So Greg had mentioned the politicizing of mask wearing as being one thing worthy of note. I'm going to try to do a quick screen share just to show a couple of slides. Hugh, just to confirm, you can see the PowerPoint slide that I have here?
Yes.
Okay. All right, so I'm going to show a couple of graphs that come from the Kaiser Family Foundation, which is going to just demonstrate some of the pre-COVID mental health outcomes related to current state of affairs. So the first one is very concerning to me as a clinical psychologist, which what you're seeing on this graph is a side-by-side comparison of the average reporting of adults of either symptoms of an anxiety disorder or a depressive disorder, so something like major depressive disorder, in the first half of 2019 compared to January 2021. So this is just a pulse survey that was administered that shows a pretty startling increase in the prevalence rates of both anxiety symptoms and depressive disorders. I'll go over some of these in greater detail, but I figured it was best to kind of give you some visual snapshots to kind of kick us off and get us concerned, and then we'll go through them in more detail. But keeping in mind that the 12-month prevalence rates for most anxiety disorders and depressive disorders float around 3 to 7%, depending on what specific disorder we're talking about. So to be seeing, a 40-something%, prevalence rate of significant anxiety disorder or depressive disorder symptoms among adults is quite concerning. Dovetailing off of that, not only have we seen in the recent history an increase in anxiety or depressive disorder symptom reporting, but we've also seen it skewed by age. So that 41% prevalence rate is heavily loaded in the young adult population and young adult to middle-aged adult population. So around 56% of young adults reporting symptoms of some type of anxiety or depressive disorder, and then going down to around 30% in the older adult population. So pretty concerning when you consider the fact that the most heavily impacted population in terms of mental health are the working population. So the young adult to the middle-aged adult population is going to be predominantly in the workforce, and not surprisingly, they're the ones most impacted by the stress associated to that. Last thing is with regards to the mental health effects on essential care and non-essential care workers. So side-by-side comparison of not only mental health distress, but substance use and suicidal thoughts in comparing them to non-essential workers. So what you're seeing on this slide is, again, another very concerning effect of the effect of the the effect of the pandemic on the mental health of the people most responsible for the treatment of the pandemic or those infected. So significantly higher rates of anxiety or depression when you're comparing essential workers to non-essential workers. A noteworthy increase, 25% of essential workers reporting substance use as a method of coping, or increased usage of substances and reliance on substances to deal with the stress. Again, comparing 25% to 11%. And then obviously the really concerning one is serious thoughts of suicide in the past month, with a 22% prevalence rate for essential workers compared to 8% of non-essential workers. So those are some concerning data points, just to just reflect on for a moment, because those are highly concerning. I'll jump in for a quick second here to provide some optimism. So one thing that we know from the research literature when it comes to public health crises is that people are extraordinarily resilient. Ted Flanagan had mentioned that, career-wise and occupationally, paramedics are an extraordinarily resilient group, but human beings in general are extraordinarily resilient. So usually what happens with any kind of public health crisis is that people get very concerned about high rates of things like PTSD, anxiety, and depression, which, as we've just seen, there are some noteworthy increases, or have been noteworthy increases, in depression and anxiety symptom reporting. But usually what happens with most public health crises is that those symptoms do tend to subside once things return to normal. And normal can be normal with or without quotation marks. In this, we've been talking a lot about the new normal, just anecdotally, when it comes to COVID. So, these are things worthy of note. People are extraordinarily resilient. Oftentimes, these are considered to be kind of abnormal reactions in response that are normal responses to abnormal situations, rather. So some takeaways, again, is that young adults are disproportionately affected in terms of mental health. When it comes to job loss in the community, people who have lost a job, this report by the Kaiser Family Foundation suggests that about 54% of adults report either some household job loss or loss of income since this time last year. And we know that when there is an economic or socioeconomic stress, that does tend to correlate with higher rates of symptoms of mental health. So there's about a 20% difference when people are financially stressed. As Dr. Castiel noted, there's a disproportionate impact on communities of color. And in addition to that, we also see that with regards to this reporting of anxiety and depression symptoms. So non-Hispanic Black adults are around 48% of non-Hispanic Black adults and 46% of Hispanic or Latino adults reporting symptoms of anxiety. So that 41% that we talked about, it's much, much higher for non-Hispanic Black adults and for Latinos. As we already talked about, there's a disproportionate impact on essential care workers. One thing I had mentioned is that there was an increase in substance use amongst essential care workers, but in addition to that, we've seen a significant increase in overdose deaths. Dr. Castiel could probably provide some local data, but generally speaking, there had been a decline in overdose deaths, for example, 2017 to 2018, but then there's been a really noteworthy increase in overdose deaths when you compare, for example, June 2019 to June 2020. So around 18% increase, which is concerning. And then it was particularly pronounced, not surprisingly, in March, April, and May of 2020, because when the stay-at-home orders were very strongly in place, we see that there were a lot of people struggling with overdose, and there was nobody to call if you were alone by yourself. He would ask me to comment on children. There was a study that was done that you can find in the Psychiatric Times that notes that about 85% to 86% of parents report changes in their children's emotion or behavior during the quarantine period. Most commonly, this was exhibited by things like difficulty concentrating, irritability, boredom. Loneliness is another really important one to note. This is a common thread between children and elderly persons. Feelings of loneliness and social isolation can have some very significant impacts on mental health. I think most people who are watching this webinar have experienced some mild version of that at some point in the past year. Human beings are historically very social creatures. So when they're put into small isolated boxes, they often feel that stress very directly. And similarly to 85% of parents reporting changes in their children's mood and behavior, about 75% of parents reported feeling stressed at some point or in some way about the quarantine situation. One positive to note from all of this, as Dr. Castiel noted, is the emergence of telehealth as a game changer in terms of the delivery of both mental and medical health services to the members of the general public. It should be noted that telehealth was increasing in utilization rates prior to the pandemic, but it has obviously exploded in the frequency of it being utilized in the last year. Patient adoption of mental health was up about 33% from 2019 to 2020 and has just gone way up since then. It's just worth noting that there were some factors that were in telehealth's favor before the pandemic hit, and these are trends that are probably likely going to stay. So for example, 88% of patients read online reviews about their doctors prior to reaching out to new providers. That was something that was occurring before and is going to likely stay. Patients are 2 times more likely to use online resources like online reviews as compared to word of mouth for trustworthy sources of referrals. So when you're looking for a new doctor, we see people more often than not preferring to go look online, just like you would do on any kind of online shopping, except it's for your doctor. The majority of patients prefer digital scheduling over calling in on their phone to set up an appointment. About half of patients, again, prior to the pandemic, were choosing their doctor based on things like the ease with which they could book an appointment online. And again, one big piece of positive out of all of this is that telehealth services like psychological services, mental health, medical services, they're known for removing barriers to care. So transportation becomes a non-factor. I think it's something like the average patient saves around 100 minutes of their time by doing a telehealth appointment as compared to an in-person appointment when you combine waiting times and transportation. So driving to and from the appointment, you save about 100 minutes with the telehealth appointment as compared to an in-person appointment. Again, prior to the pandemic, about 93% of patients reported that they would use telemedicine to manage prescriptions. 91% reported that they would use it to stick with appointments. As some of us probably note from having provided telehealth or teleconferencing, it's not perfect. There's a lot of barriers that come into it, things like access to technology, the degree to which we worry about things like Zoom fatigue with providers. So there is research to support the fact that Zoom fatigue is very real. I was just sending an email to my colleagues about an hour ago. Stanford University actually developed the Zoom fatigue scale, which you can take. It's a 15-item questionnaire that's designed to track the degree to which you're feeling fatigued by all those Zoom-based teleconferencing meetings. So that's something obviously to keep in mind. And then I'll wrap up by just talking about obviously the post-COVID trends with regards to telehealth. The term I really love is the Uberization of healthcare. So the idea that telehealth and telemedicine kind of mirrors today's expected consumer experience with regards to telemedicine. We expect there to be online reviews, we expect easy access, good communication, and that the technology is going to be reliable and dependable. So that's not to say that you're not going to disregard the primary care physician that is in the same zip code as you, but predictably about 75% of people would say that they would prefer to use telehealth to see a physician with whom they already have a relationship. But interestingly, about half of patients would say they would use telehealth to find a new doctor. So there's a possible trend of test driving, taking physicians for a test drive to see if it's a good fit for you, as opposed to being the only doctor closest to you. And with telehealth, it's so new for most practitioners. The majority of practitioners don't have a lot of experience in being trained in it and being trained in the provision of whatever their practice is in telehealth. So I'm going to wrap up there. Back to you, Hugh.
Sure. Thank you. Dr. Pratico, I really appreciate you bringing up Zoom fatigue on a Zoom webinar. No, just kidding. At this point, we will begin our panel discussion and address audience questions. Once again, please use the Zoom's Q&A feature to send your questions. If we don't get to your question today, or if you don't feel comfortable sharing it in this format, you can email your question to info@annamaria.edu and reference the Life After COVID webinar, and someone will get back to you that way. So let's start with Dr. Castiel, because Dr. Castiel, there's a question that's been submitted in the Q&A from Kathleen Rowe. Dr. Castiel, are you seeing a larger degree of vaccine hesitancy in vulnerable populations? Can you speak to the ways that you combat the psychological barriers as opposed to ways you increase access and convenience for these groups?
So there started off to be a large group of people in the community and communities of color that actually had a lot of hesitancy. I think we started off even before the vaccines were coming out to have these town halls with trusted community leaders. So, you know, in the Black community, who are the docs, who are people that they feel comfortable with, in the African community, the Latino community, all the different communities, who are their trusted leaders, and those who are in medicine to be able to speak about it, and then demystify everything that people have been thinking about. There's been a lot of stuff on social media, you know, whether they put chips in people, you know, that infertility, all these different things that people are thinking about, or how fast the vaccine was rushed, but then to really talk about those issues. And again, to have people ask questions. And then truly, a lot of it also has been the outreach into the community, and going there and talking to people. And that's been a process that's been going on truly since the pandemic has started. And that's been our goal. I think one of the pieces that we work with in our department is really working with the community and working with the leaders in the community. And that's partly everything that I've done is actually work in the community so that we know who's out there and we're able to work with them. Again, the data has also shown us where to go and how to outreach to that particular community who has the highest positivity rate. I don't know if I answered all of it. Did I miss a part, Hugh?
No, I think Kathleen, feel free to send another chat if you have a follow-up, but I think that does it. Let me again, some people submitted some questions in advance, so I have a list here of some additional things to talk about. Dr. Ciottone, can I turn to you, and others can chime in as well on this. Is normal, you know, return to normal or a new normal, is normal even the right term, or is the goal going to be something very different?
That's a great question. And if I could answer it accurately, I'd go out and buy a lottery ticket right now. I don't think anybody knows honestly what the new normal is. You know, we can model probably some of what it'll look like on past human behavior. Everything from pandemics, but also like post 9/11 and some other major events where, you know, in this kind of world of disaster medicine, we're all too often reactive and not proactive enough. So an event happens and all of a sudden, you know, your preparedness, mitigation, et cetera, all the steps you take, you know, very, very ramped up, but then they tend to tail away. If I were to try to predict what the new normal is going to be, I do think that we're going to get an annual COVID booster, you know, much like we get influenza shot every year. They're probably going to be mixed together if they're able to be. And I think that we're probably going to go to some, you know, I don't think Zoom is going to go away. I think, you know, some of the workforce is going to stay shifted to remote activity. I think probably we're all going to get back to school for the most part. But I think, you know, it's going to be a modified new normal. And as far as the degree of non-pharmaceutical interventions that we're going to use, mask wearing, social distancing, et cetera, in the future, there probably, as we come off the first couple, 2-3 years, you know, on the other side of this pandemic, you know, still going to be, you know, different, meaning, you know, we'll still be wearing masks in some situations. We'll still be, you know, recommending some social distancing in some situations, perhaps. But I think they're probably going to slowly kind of tail off. But, you know, the one big concern, the one really big variable in this are the variants. And again, I can't emphasize this enough. It's great that the United States will have enough vaccine for every single American by the end of May. It would be even better if we could vaccinate every single American by the end of May, which of course we won't for multiple reasons. But the fact that the most of the world, including the vast majority of the developing world, will not even begin to see this vaccine until some point past that, and the rollout in most of the world is going to be much, much slower, means that the reservoir of virus around is going to be still significant enough in the coming months to perhaps a year and more, that the emergence of variants is possible. And as this New England Journal article just demonstrated a couple of days ago, not definitively, but shows indication that perhaps some of these variants will have some not protection, but would essentially be somewhat immune to the vaccines that we have. We have to create modified boosters. So until we can chase this virus down to its smallest, small little pockets here and there, not allowing it to have that massive virus to allow kind of variants to emerge, I think we're going to have, again, this kind of crisis pivot left and right on us for a while, which is going to influence what our short-term new normal looks like and then long-term new normal. So it's kind of a roundabout way of answering it, but yeah.
And Hugh, if I could add that one of the things that certainly was brought out with COVID is the inequities that exist in healthcare, and the inequities that we've known existed for a long time. But there's a light shined on it, and we're hoping that, looking at how the vaccines were rolled out, and to think that it was all rolled out with an equity lens, and even the piece about having equity vaccines. So I'm looking forward to the future, that we actually have more research with communities of color, that we get more data regarding this, and our focus would be to really provide equitable healthcare for all.
That's a very good point. And actually, you used the word data, and let me just, it's interesting to me because one of the things we've grown accustomed to throughout the pandemic is this daily data update, and the value of having information like that. Is that how long does that stay with us? Yeah, and I pose that to the panel.
So I think for us, data is probably the most important thing. It's how we act, really, how we come up with conclusions. And without the data, we can't function. We're not able to say what is needed, and community throughout needs to hear what is in order to get these vaccines, and in order to have an equitable process. That data is an important piece that we needed to be able to prove what was happening in the community. I think Dr. Ciottone mentioned, the variants and the data, where they are and what's happening. It's an important piece to think about. So there's different ways of looking at data. I'm just going to point to that one, but.
Yeah, I mean, I absolutely agree. If I could add to that too, data is one thing, but it's what we do with the data, how we use it, how we convey it, and where the lay people get their data from, which is equally important. I mean, absolutely, Dr. Castiel, I completely agree. Everything that we do on the medical side, healthcare side, science side needs to be data driven, absolutely. But if we're not able to convey that data in a public education campaign effectively, and essentially convince or show the community how, really until we get very much on the other side of this pandemic, how we need to continue to have the community save itself with all these different non-pharmaceutical interventions, balanced with vaccines, balanced with effective therapeutics, maybe at some point, we can have all the data we want, but it's not going to be useful. It's that translation down to where the rubber meets the road in public health that is going to be, I think, the most use of the data that we can have.
The next question is probably directed to Dr. Pratico, but again, it's open for everyone. In many ways, the pandemic has brought people together despite social distancing. What are some of the ways, or how can we continue this sense of community and shared sacrifice?
Yeah, it's interesting because the social isolation piece is a lot of what we felt personally, right? It's like when was trying to track it down as we were going, but I'm fairly certain today is the anniversary of my first ever Zoom meeting. And, there's something about it that it feels, so like a Zoom meeting, this is partly anecdotal, but it's cognitively loaded. You have to really focus on a lot of what's going on that you normally can't do in a conversation, which is most of us don't have conversations with our peers while we're facing a mirror of ourselves and see how we are. And so a lot of times when it comes to these electronically based attempts at interacting with each other, they're like close but not perfect. And I think that's where a lot of us, it's like we've missed seeing family members face to face without a mask on, because the more you're hanging out with people, the more risky it is in terms of virus transmission. So then you're reliant on things like teleconferencing software, whether it's Zoom or FaceTime, which was great in April. I was talking to a colleague of mine where I said, can you imagine how this would have gone had this pandemic happened in 1995 as compared to 2020? It's incredible. The fact that, my daughter was able to FaceTime with all of her grandparents and still maintain some semblance of connection. At the same time, my daughter did not see another child physically for about 4 months because she's an only child and she was just stuck at home with me. And my wife was an essential care worker. So it was me and my daughter for months and months and months on end. So, that's kind of been the crux of it. And I don't really have a good metaphor for it, but the fact that this escalated so quickly when it did, and the fact that things are getting better kind of week by week, it's kind of like aging, I think, where it's like you don't notice it on a day-to-day basis, but one day you look in the mirror and you go, where did that come from? Or, where did this like wrinkle come from? And I think that's where COVID like reemergence is going to feel as well. We're not going to necessarily notice it day by day, but then, you're going to notice it more on a month by month basis in terms of the social piece.
When you get to be our age, you'll start noticing it day by day.
I just wanted to add also that one of the things socially, if you want to say, but also working together has been a piece that I've noticed. And, in Worcester, they started the Worcester Together group, which is lots of people from different agencies working together for goals that they probably didn't even work on before. And for us, also the collaboration of different agencies for the same goal has been something that hasn't happened before. And these are things that I hope in the future continue to happen. We've sort of worked in silos in the past, and this collaboration has been amazing. And also just people overall who, you say at times when things are going bad, the best comes out of us, and people working together has been just something that has really impacted all of us. And that working together with Worcester, which is two foundations that got together, and everybody in the community to really look at issues of homelessness, food, everything you can imagine, that people who were COVID positive and were quarantining were able to have food brought to their house, for the 14 days that people were in quarantine. So amazing things that we pulled out of our community and got to know other people in the community because of it.
I think it's important to recognize again that families are extraordinarily resilient. People in general are quite resilient, and that comes out in social ways as well. So yeah, we saw some really interesting things just on our campus with our students. They were doing very creative things in order to be able to still just see each other and try to get an average college experience, in a very weird year. So, there were some very creative ways to kind of hang out and see each other and still, still be friends and colleagues.
That's a perfect setup for another question that came to me, which is you're all affiliated with higher education in some way. How are you adapting kind of what you've learned, the lessons learned from this experience? How is this all being adapted into classroom curriculum?
I can speak to EMS. I made a comment once during a staff meeting at the college, and I think people sort of looked at me a little funny, but at the end of it bore some significant truth in that the pandemic for EMS education is understanding it's a tragedy and it's had awful effects, but as a learning laboratory, it's one of the greatest tools I've ever been able to have as an instructor, in the sense that most of my students are practicing EMTs. That's the ones that are either pursuing just a certificate program, so they're working as EMTs and they're only at Anna Maria for the paramedic curriculum, or the folks that are there for the bachelor's degree. They all tend to be working in EMS, and so it's brought home very clearly and very directly sort of the forces in EMS at play in the profession that might have taken them a couple of years to understand prior to the pandemic. So simple things like just being able to explain the how the cost of doing business can change, and how one of the long-term things results of COVID is that there's always going to be testing and PPE costs, and eventually right now a lot of these things are given to us by government, state, local, federal government on sort of a crisis footing, but eventually this is all going to transition, and we're never not going to be investing in PPE and that sort of thing, and COVID testing and vaccination. And I could explain to students, we talk a lot about how is EMS funded in America, and it's really, for the municipal services, it's not so difficult, but yet the vast majority of medical transportation in America is non-emergent, and it's completed by for-profit private ambulance companies. They're doing noble work, but at the end of the day, there is a profit motive there that they need to stay in business. They need to achieve their goals. So the cost of doing business for the private companies is undoubtedly going to rise, which puts stress downstream on all of EMS. And I think so. There's a reckoning to be made with the cost of what COVID is going to cost us financially going forward. And so, as an educator, there's a wealth of new vistas to discuss, and new ways to explain things that before would have been a little harder to get across. They're seeing more the profession laid bare by the pandemic, and so things that might have taken some digging to understand are right there, particularly financial, and then how do we even organize the allocation of resources in a resource finite profession, in which we could conceivably treat there is no corner. I mean, I think it's one of the defining differences of EMS from most emergency professions, that we are welcome literally into every corner of every house, for every culture, for every person. They generally want us there. They're happy to see us. When I worked for Worcester EMS for all those years, one of the best parts of the job was going to visit people in places and cultures that I might not have ever interacted with. And so COVID has really accelerated that learning curve, I think, for EMS anyway. I wish we hadn't had to go through it. There is definitely a silver lining.
Thank you.
I think for higher ed, we've become, as the resilience word has come up several times, but when we established that our classes would turn remote, totally something that we didn't expect to do, we were able to turn around and continue educating our students within, I would say, I think we took a week to figure out how we were going to translate our courses into online and remote learning, and we did it in a week. And quickly learned that the last letter of the alphabet is Zoom. It isn't Z, it's Zoom. And thank God for that technology. But the classroom environment is different. We're able to offer our courses with students in the classroom and students in Zoom. The different types of technology that was introduced into the classrooms is different than it was a year ago today. We now have a device called an owl. We've got owls in our classrooms that is a microphone and camera that actually follows the instructor around, and would have never happened unless we had the COVID piece. So all of our students were able to meet the student learning outcomes based on the fantastic work of our faculty our administration, and whoever heard of we'd have a COVID committee led by Mike Myers, our CIO and COO of Anna Maria College. And, you know, going through and writing up infection control practices, having someone cleaning all the doorknobs throughout the college still exists today. Hand wipes outside of every classroom. Our COVID co-verified testing twice a week. The college is continue to test twice a week, where students, you know, have to show you're cleared before you come in. So it's really turned around to be student safety, staff safety, faculty safety, academics, and our priorities, where we're always a safe environment here at the college, but now we're highly accelerated our infection control practices into the classroom. So it's just becoming standard operating procedure. John, I don't know if you want to add something as a faculty.
Yeah, I think one piece of it, the name of the game has been flexible. That's been a huge piece as a faculty member. Obviously, as somebody designing courses that have always been taught on ground, to then teach them remotely or to teach them in some type of hybrid or online formats, it requires a fair degree of flexibility on the faculty then, but then obviously on the student end as well. You know, my heart has gone out for the students who are taking classes remotely that would love to be on campus, but can't because they have something going on in their lives or they don't feel comfortable, you know, taking classes on ground. A big area where we've seen things be affected, Hugh, is with regards to our field placements and our internships. Many of our academic programs have very strong internship programs. And so to see those either be adapted significantly and adapted either through some type of remote option. So we have several students right now that are kind of remote placing into their school districts or to the hospitals, or the school has either had to come up with some other way to navigate that. I'll say this much: I have a batch of counseling psych master's students because we have a licensed mental health program on campus where their entire clinical training has been done through telehealth. So in some ways, they're extraordinarily well prepared for the world into which they're going. You know, they were learning about telehealth concurrently with their supervisors. You know, the learning curve, they were on the same learning curve as their supervisors. And then I've had some of them express concerns because they say, you know, I'm going to be going out there and getting a job as a therapist, and I've never met with somebody face-to-face to do counseling. And so in some ways they're in this weird place where they're going to have to learn what it's like to sit down and do behavioral observations in person, when that's something that literally every other cohort has gotten as part of their clinical training. And obviously most of them will be perfectly fine and able to adapt those skills over. So adaptability and flexibility has been kind of the name of the game on our side.
Yeah.
Thank you. We have time for probably one more question. So one of the questions that was submitted is really about the private sector, although we could probably shoehorn in emergency managers to this, but it's really about how has the pandemic affected people involved with business continuity or disaster planning roles in private sector organizations. How have they been changed? And maybe I should start with Dr. Ciottone on that one.
Yeah, so I mean, again, much like the educational sector and some others, they had to figure out a new normal. And I know just through my interaction with some various businesses that asked me to give some opinion on some of their practices. You know, it's been this whole idea of how do you scale up these social distancing and different procedures, and then in the summertime, how do you scale them back as we're going through the different phases of reopening, and then as a second surge predictably hit, you know, how do you scale them back up? And now we're somewhere in the middle. So I mean, I think your average business owner, quite frankly, is confused. And you know, I was able to, when I was talking to some over the summer, let's say, just tell them, listen, you need to look at the disease prevalence in your communities and what's going on exactly where you are. And then balance that with what the CDC's, suggesting you do and the state suggesting you do, et cetera, and do it that way. Now, I don't think that even works because there's just so much confusion, and not not that it's anybody to blame on that. I think it just these are uncharted waters. We just haven't been here before in the midst of the most significant global pandemic since probably 1918, and in this idea of the largest vaccine rollout in the history of mankind. We never had vaccines in 1918. We just started to have them in 58 and then in 68. But not to this, we weren't doing this scale. So it's all uncharted waters. So I think businesses are confused, quite honestly. But I think if I were to give advice on the private sector, I would say, again, where you are, look at the situation, because we behave certainly like 50 different little microcosms, and even smaller than that in some cases. Even some states, we're behaving differently in different parts of the state. So look at where you are, look at things like disease prevalence, what the Department of Public Health, Health and Human Services, et cetera, is recommending for your region, and try to follow those guidelines and try to scale down as vaccines scale up.
Anyone else on the business side of things? Okay. Well, again, we appreciate everyone's time today. Thank you for joining us. If you have additional questions that either that you thought of after the fact, please email them to info@annamaria.edu and reference the Life After COVID webinar. I want to especially thank today's panelists, Dr. Castiel, Dr. Ciottone, Ted Flanagan, Dr. Pratico. Thanks to Judy Canary for organizing this, and to Anna Maria College for hosting this. To learn more about Anna Maria College, please visit annamaria.edu. And again, we've recorded this session. We hope to make it available on the college's website in the coming days. Thank you for joining us. Good afternoon.